At this San Antonio, we presented our phase 1 trial of the PI3 kinase inhibitor Copanlisib in combination with Fulvestrant and with Abemaciclib, kind of triplet therapy in patients with metastatic hormone receptor positive HER2-negative breast cancer. So this trial was conducted through the NCI ETCTN program. So it's an NCI study. The rationale for the study is that PI3K inhibition can delay or prevent resistance to CDK4/6 inhibitor and hormonal therapy in ER-positive breast cancer. In addition, CDK4/6 inhibition could also overcome resistance to PI3K inhibitors. So there is significant preclinical data that triplet therapy can be synergistic and more effective than doublet therapy of endocrine therapy in combination with either CDK4/6 inhibitors or with PI3K inhibitor. So in this trial, we used the PI3K inhibitor Copanlisib. So this is a drug that's being developed between NCI and also Bayer. So this drug was previously approved actually for the treatment of follicular lymphoma, although lately it was withdrawn for that indication. But the idea is that this particular PI3K inhibitor is intravenously given once a week. So kind of you can completely shut down the PI3K pathway in a short period of time so that you don't have a lot of lingering toxicities when you combine with CDK4/6 inhibitor. So this particular PI3 kinase has activity predominantly against alpha and delta. And we know that alpha is very important for breast cancer, especially the PIK3CA mutated breast cancer. So in this trial, we first did the phase 1 study, which was what we presented. So we tested the Copanlisib in combination with Abema and Fulvestrant at 4 different dose levels. And so initially, we had the dose level using Abemaciclib at continuous dosing. So Abemaciclib as single agent is approved with 150 milligram BID to combine with Fulvestrant. So in this trial, we started with a slightly lower dose, 100 milligrams twice a day. And Copanlisib also started at a lower dose of 45 milligrams rather than 60 milligram, which is approved dosing. And we gave intravenously day 1, day 15. So that was our dose level 1A. So we enrolled 7 patients to this dose level. 6 patients were evaluable for dose-limiting toxicity. And then we found 1 patient that had a dose-limiting toxicity with grade 3 neutropenia. And this led to a dose reduction of Abemaciclib and also dose interruptions, leading to less than 75% of the Abemaciclib being given within the first cycle. So that met the DLT criteria, so 1 out of 6. So this way, we were able to escalate to dose level 2A, in which Abema maintained the same dose, 100 milligrams twice a day, and Copanlisib was given 45 milligrams. Now we are adding day 8. So now we have day 1, day 8, day 15. And this turned out to be intolerable. So when we enrolled 3 patients, 2 patients developed dose-limiting toxicities, with 1 being grade 3 rash and 1 being grade 3 hyperbilirubinemia. So, since dose level 2A exceeded the maximum tolerated dose, we would have thought that the dose level 1A would have been the recommended phase 2 dose. However, what we found was in subsequent cycles, although dose level 1 was tolerable at cycle 1, but in subsequent cycles, there were frequent neutropenia that led to dose interruptions of the Abemaciclib and dose reduction. So among the 7 patients that we enrolled to dose level 1A, only 1 patient was able to maintain the 100 milligram twice a day. And other patients, had to dose reduce to 50 milligram twice a day. And 1 patient had to discontinue Abemaciclib due to cytopenia. So because of that, we added part B of the phase 1. So essentially going back to the original dosing, but with Abemaciclib given 5 days on, 2 days off schedule. So the dose level 1B started with 100 milligram twice a day of Abemaciclib given 5 days on, 2 days off each week. So the idea is that with the intermittent dosing, we would be able to reduce the cytopenia side effects. So we combined with Copanlisib, initially 45 milligrams given day 1, day 15, so similar to dose level 1A in combination with Fulvestrant. So with this dose level, it was tolerable. We observed 1 DLT, that's grade 3 rash, out of the 6 evaluable patients. We were able to dose escalate to dose level 2B, in which we added Copanlisib on day 8 as well. So similar to dose level 2A, except that Abema is given in the intermittent dosing. And 2 out of the 5 patients evaluable for DLTs were found to have dose-limiting toxicity. So 1 patient had grade 3 new onset atrial fibrillation. The other patient had grade 3 rash. So this exceeded the maximum tolerated dose. So going back to dose level 1B, because cycle 1 was tolerable, but compared to dose level 1A, the subsequent cycles, the regimen was much more tolerable. Majority of the patients were able to maintain the dose of Abemaciclib and the Copanlisib as we intended. So this was defined as the recommended phase 2 dose, so dose level 1B. So overall, the study enrolled 24 patients, and the most common side effects at all cycles were diarrhea, nausea, fatigue. There were also Copanlisib infusion-related hypertension that was transient, and neutropenia, mucositis, rash, liver function abnormalities, and also hyperglycemia. The most common grade 3 and above adverse events in all cycles were transient grade 3 hypertension in 42% of the patients that resolves fairly quickly after, the day after the infusion. Grade 3 rash in 29% of the patient, grade 3 neutropenia in 21%, and grade 3 anemia in 21%. So grade 4 adverse events were actually rare. There were 2 patients had grade 3 pneumonitis, and this all happened at dose level 2B. This actually resulted in 1 grade 5 toxicity. So the efficacy were evaluable, with the response in 21 patients. There were 5 partial responses, and 4 patients had stable disease for at least 24 weeks. So the clinical benefit rate was 43%. Among the patients that enrolled to the trial, there were actually 42% of the patient had liver metastasis, and the median prior regimen was 1. 58% of the patient had prior Fulvestrant. The majority, 83%, had prior CDK4/6 inhibitors, with majority being Palbociclib. And also 8% of the patient had prior PI3K inhibitor. Among the 17 patients that we have genomic information available, 47% had PIK3CA mutation, 24% had prior ESR1 mutation. So this is in the post CDK4/6 inhibitor regimen for majority of the patients. And with the response rate, clinical benefit rate, I think is pretty good. And the median progression-free survival was 25 weeks. So when we look at individual patients, the responses were actually seen in patients with or without PIK3CA mutation, and of course, also in patients who had prior CDK4/6 inhibitors. So we concluded that with the intermittent dosing of Abemaciclib, we were able to identify a recommended phase 2 dose for future studies. And the grade 3 above toxicities were as expected for combinations of Copanlisib and Abemaciclib. And we did observe preliminary anti-tumor activity Ongoing studies include pharmacokinetics analysis and correlative studies of baseline tumor and serial ctDNA analysis to investigate potential treatment response biomarkers.